my hope and my wish is for every CTA bus, every CTA station, and every CTA train to actually carry Narcan on them to be able to get that life-saving medication to the person that needs it in real time.
Erik McIntosh, great to have you here. Welcome to the show.
Thank you so much.
To build context to the listeners, like I stumbled upon your name across various articles referencing the initiative to try to put a Narcan vending machine on the CTA, or at specifically the 95th stop on the Red Line. Mm-hmm. But you've also been a part of the heroin or opioid task force on the West Side as well.
Yeah, so the West Side Heroin Opioid Task Force.
Okay, and who comprises that task force?
So it's a bunch of community members,
okay.
And I'm specifically part of the arm of the CTA Narcan task force. So it's kind of a side committee arm of that
it's
initiative.
A little more focused for you.
Yes.
Okay.
Yep.
Okay.
Yep.
And to build even more context, in the articles it stated that you've had personal experiences on the CTA that led to this initiative.
Yeah.
Can you share those perspectives
Sure.
or the experiences?
Yeah. So, I moved to Chicago in 2004.
Okay.
And I have been a lifelong CTA writer. And so between, I've lived in Lakeview, I've lived in University Village, downtown, now in Wicker Park. And so the bus system and the train system, that is my mode of transportation. And, it's, for me, having a regular job, I'm pretty predictable as far as my schedule goes. And so, I show up to the same bus stop or CTA station at the same time.
How many ghost buses have you come across?
Oh, let's not talk about the ghost buses. Never train, very rarely train, but yeah, ghost buses are an issue. Podcast for another day, I think, with that one. And it's interesting because, you get to know people. And so, people keep a fairly regular schedule like I do. And so you really start to see familiar faces and it's kind of a weird community because you recognize each other.
Like you acknowledge each other, right?
100%.
Okay.
Yeah. And so, and then you'll find yourself sometimes thinking like, oh, where's,
like if you saw them running for the bus, you'd actually speak up and be like, wait, there's
he's
someone.
Coming, he's coming. Yeah. Yeah. 100%. And then if they're not there, I'm like, wait a minute, it's Tuesday. Why aren't they here?
No.
Are they running late? Are they off today? It's just kind of, these stories that you create in your head about these people that and so really, they have really become an extension of my neighbors and my coworkers and my family, because these are the people that I see every day. And so this is one particular night. Like I said, I take the mix of between either the train or the bus. I got a ghost bus. Speaking of ghost buses. So I was like, all right, the blue line's coming. I'm just going to run down. Instead of grabbing the Damon bus, I grabbed the blue line.
Okay.
And again, the blue line has been a staple for the 20 years that I've lived here. And so I got on, and there's one particular woman that I had recognized for the last number of years. Again, I don't know her name. But I know I've seen her different times of the day on the blue line. But anyways, I sat down. This was the end of a 14-hour shift, exhausted. I was just gonna play some Candy Crush and just zone out. And as the train got going and we had gone underground, a guy ran up to, so I always ride the first car, and a guy had run up to the conductor's door and started pounding on the door saying a woman's unresponsive. And so, my nursing instincts kicked in.
Sure.
So I looked back, and it was this woman that I recognize or I'm familiar with, and she was slumped over in her seat and nearly collapsing to the ground. So I rush over, I start, sternal rubbing her, trying to get her responsive.
Yeah.
Eyes barely opened. And so, of course there were people gathering around, seeing what she needed. Some guy gave me a candy bar. He's like, she's probably a diabetic. I'm like, she's not even like opening her eyes. She's not going to open her mouth to me to shove this, Snickers bar down. But I knew she wasn't a diabetic.
What is it about milk? I hear that often. It's like, they need milk.
Oh, well, so actually, interestingly, so milk has some sugar and protein in it that actually lasts longer than like a juice would.
Like casein?
And so, or
something other.
Yeah, that's one of the proteins.
Okay.
But yeah, so there's actually,
I didn't know that.
yeah, that milk actually.
But more for diabetes then, or more for like opioids?
No, not at all.
Okay.
Oh, milk, opioids?
No, yeah.
Not
okay.
at all.
All right.
No,
Just
it's
someone.
not gonna do
I guess
anything.
they're not making the association. They just see someone maybe they're associating with
Unresponsive.
hypoglycemia.
Yes.
Okay.
Exactly.
Okay.
Exactly. Yeah, that's where the milk piece comes
Gotcha.
in. So I looked her over and I noticed she had track marks in her in her hands.
And for those that are unaware, like what would track marks look like?
Yeah, that's a great question. So they're like, how do I explain it? So they're like tiny little marks or holes that you'll see usually along people's veins.
Okay.
And sometimes they can be red, scarred. You'll typically see them on the forearms. People who have a drug addiction will find various places where they can find veins. And so that's typically the arms. And so you'll see and it's kind of like a line of different places that people have gone in to inject.
Because over time it's scar tissue and it's harder to inject?
Mm-hmm.
Okay.
Yep, because they use and overuse that same spot.
Gotcha.
Until it doesn't work anymore.
Okay.
Until it gets so scarred that they have to move on. And so I saw that in her hands.
Mm-hmm.
I'm a nurse practitioner in hospital medicine, and part of the patient population that I treat are those with drug addiction, and so this was very familiar to me. And kind of her, the slowed breathing, the nodding of her head. I looked into her eyes; they were pinpoint, and
which
so
means
this is
very constricted,
yeah,
right?
very constricted, very small. So these are all signs of an opioid overdose. So I knew this was most likely an opioid overdose. And so, speaking of antidotes, milk is not one of them, but Narcan is. And so Narcan is an opioid blocker, essentially, that you can either give it through the muscle or through the nose, through a spray. And when it is given to a person who has opioids in their system, Narcan essentially kicks that opioid off
The receptor,
the receptor, and then binds to it, and so it starts blocking.
Does it have a greater
effects.
affinity for that receptor?
It does.
Okay.
Yeah, and so it's able to compete with the opioid and block those receptors.
And what is, because on the pre-hospital side, our goal with Narcan is to restore adequate ventilation or breathing, rather than wake someone up.
Yeah, well, yeah, and actually that's essentially what Narcan will do. And so what happens is with opioids, when they bind to the receptors in your cells, it affects your central nervous system. And the biggest effect that opioids do is give a feeling of relaxation, sometimes euphoria, and takes away pain. And that's an intended effect if you are in pain. However, one of the side effects and the dangerous side effects is it can suppress your central nervous system. And so that means when it suppresses it, loss of consciousness, decrease in breathing, and then slowing of the heart rate. And so, which could eventually lead to death. And so if someone has too much opioids in their system, or the body is not used to it, that can be an unintended consequence. And we would say would be an overdose. And so the Narcan...
And Narcan was recently approved for over-the-counter. I think
was.
the 4 milligram nasal spray.
Yeah, which is exciting. Before it was prescription, and then it was what we call back-of-the-counter. And so it was a medication that was behind the pharmacist. And so you would have to go up to the pharmacist and ask, if they had Narcan available for purchase. And not a lot of people know that.
No.
And so, and there can be barriers too for pharmacies to actually get behind the counter Narcan. There are certain state laws that can really regulate.
Which is weird because there aren't too many. What side effects are there of Narcan? I know there's like flash pulmonary edema in like very severe cases, but aside from that,
not much at all. It's a very safe, and in fact, that's why the FDA just recently approved it to be over the counter. And so over the counter meaning that you don't need to have a provider regulating and controlling this medication because it's safe for public general use.
Yeah. Which then comes the education component, right, of administering it.
Yep. Yeah. And basically, if you've ever used saline nose spray or Flonase, you're going to know how to use this.
Okay.
And it's pretty simple. Of just taking it out of the package and then inserting it into the nostril and pushing the plunger, and then it gets deployed. And the nice thing with it over the counter now is it's out for the general public to see, to purchase, and then if they do have questions, there's the pharmacist there that'll be able to help educate them to know how to use it. But like all medications that are over the counter, there's instructions, and so you can read the instructions as well. Once you bring it home, and so I yelled out like, anybody have Narcan? No one did. And I got some strange looks, people haven't heard of it. And so we finally pulled into a station, and they've called EMS, and we're just waiting. And so I step out of the train, and I go to the train conductor, and I said, hey, do you have Narcan available? And she said to me, even if we did, we couldn't give it, which maybe according to CTA policy may be true. But actually we have an Illinois state law that protects a person, a bystander giving Narcan from any sort of legal repercussions. And so you can actually give Narcan as, a non-medical
Is this specifically
person.
Narcan or just like Good Samaritan law or something more specific?
No, this is actually specific to Narcan.
Oh,
yeah.
okay.
Yeah. I think it was like in 2010, this law came into effect.
Okay.
And so, anybody can give it. Now, let's say, this woman that on the blue line, let's say, I'd said, okay, she has an opioid overdose, but maybe it really was diabetes. But I gave her Narcan instead. Nothing's going to happen.
Yeah.
There's going to be no real side effects for her getting Narcan and not having any opioids.
Sure.
But if Narcan had been available to me and I gave it to her, what I would see is the automatic reversal of the side effects of blocking the opioids.
And that nasal spray, it says 4 milligrams, but is it 2 pumps or like 1 pump in each nostril? Or
No. So what it actually is, so usually in the package it comes in 2.
Oh, okay.
And you deploy it in 1 nostril first. Now, what happens is it depends how much opioids are in the person's system. Sometimes just 1 spray will get them responsive and up and completely reverse what they've taken. For some people, if they have a lot in their system, the effect will only last so long, and then they'll go back into the
overdose,
respiratory depression.
Oh, wow.
And so they may need or likely will need a second administration.
Yeah.
And so that's when you pull out the second one, put it in the other nostril, and deploy it.
Interesting.
There are some people, though, that there's so much on board that they will need repeated doses.
Oh, I've
usually
heard 8
in the
to 10
emergency room.
milligrams sometimes.
Yep. Yep. And so, but the biggest thing is you want to start reversing it as early as you can until they can get an EMS response there. And so, unfortunately for this woman, time just ticked away. And it was about 10 minutes from the start of her being recognized as being unresponsive to EMS actually getting there. And in that,
it's actually not bad for Chicago.
No. Okay, that's good to know.
Ideally a 7, but
okay.
I've heard 20, 25
Oh
minutes,
God,
so.
it wasn't that long.
No, yeah.
No, so, so they got there, and I relayed to them. I said, I'm pretty sure she's overdosed. She's got track marks in her arms. I'm a nurse. This is my assessment. And then I got right out of the way because they like to get to work, They don't like people around them. But, that was 10 minutes of decreased oxygen to her brain,
right?
Opioids taking more effect of her body, slowing her response down.
What if they took longer? Would you assess a pulse eventually?
Oh, yeah.
And then initiate CPR?
100%. Yeah. And so that entire time that I was with her waiting for EMS, I had my finger on her pulse, making sure that, she was, and still trying to keep her aroused and responsive, which she really wasn't for me. But had she gotten that Narcan, what I could have expected is her to wake up. If she was taking opioids for pain, she would have been in pain because, that blocks pain receptors and all that. And people are usually very confused and just trying to figure out what's going on. Some people may be upset.
With the dose of 4 milligrams, or if you had to give 2, would that be 8 milligrams then with the second one? Have you seen agitation, vomiting, right?
Oh yeah.
Withdrawal symptoms, right?
Withdrawal symptoms. Yeah.
Okay.
Yeah.
Okay.
Yeah. And so when a person is coming off opioids, the withdrawal symptoms can be really severe. Yeah. And in fact, people will be hospitalized for 2 to 3 days just to help them recover from withdrawing.
Yeah.
And we've got medications out there that help with that process for people coming off of opioids. So there are 2 medications right now, buprenorphine and methadone. So those are the 2 medications that we use to not only help with withdrawals, but then also maintain people in an outpatient setting. So that instead of taking the heroin or whatever opioid that they're addicted to, they take methadone every day, for example, to prevent them from relapsing.
Sure. At this point, I'm curious about your personal journey into nursing and healthcare.
Yeah.
Can you take us back to when you had an inkling of I want to be some type of healthcare provider?
Yeah. Very young age.
Oh, wow.
So my mother's a nurse, retired. My aunt's a nurse, retired. So it's kind of always in, my family.
What kind of nurses were they?
So my mother, she did hospital medicine and then retired working in long-term acute care nursing homes. And then my aunt was an OR nurse. Ooh. And then she eventually transitioned into preoperative, seeing patients before they went into surgery. And so, which was great, for my aunt, because she would bring home all these cool stuff. And so discarded IV tubing, not used. It just, it had gone on the sterile field and they got contaminated. So instead of throwing it away, she's like, oh, Erik will like this. He'll find it fun, And so I got all these really cool different medical stuff.
How old?
Oh, I was probably 6 or 7.
Wow.
And so I was introduced
toys.
It was toys. It was toys. I was, my friends were interested in G.I. Joe and Star Wars. And I was like, no, I got this IV tubing set. And then what I would used to do is I would take a shirt of my shirt and pants of my dad and stuff them with newspaper.
Wow.
And then I had my buddy, I don't know, it was like a toy in the it was a doll for boys in the 1980s called My Buddy. And I would just stuff him in there so he would have this little head and then the stuffed shirt of newspaper. And that was my patient.
Okay.
And so
so you would come up with scenarios and stuff?
100%. Oh, yeah. And at the time, this is what was interesting. At the time, I thought I was playing doctor.
Okay.
But in reality, I was really playing.
What you were actually doing.
I was being a nurse because I was tending to my patient. I was administering medications, watching for side effects. So, and so growing up, I kind of always had this desire to help people.
Yeah.
For a little bit, 5 or 6, I was saying I was going to be a priest and a doctor. So I was going to be a doctor priest, and then later on, through high school and then starting into college, I was still very interested in medicine. And
Okay.
so I was like, well, maybe I'll be a PA, maybe I'll be a physician. I'm not sure. So in college, I studied biology.
Yeah.
Actually, my undergrad didn't have a nursing program.
Hmm.
And nursing still for me was kind of like, well, no, that's what girls do.
Oh.
You know, so there's still very much
Sure.
of this like stereotype.
Sure.
And so after college, I didn't know what I was going to do. What are you going to do with a biology major?
I'm not doing
much.
anything with my biology.
Okay, see? Yeah, not much. And so I kind of took a gap year.
Okay.
And what I did was I joined AmeriCorps.
Oh, cool.
And so I became an AmeriCorps volunteer, and I got assigned to Washington, D.C., and I worked as an activities coordinator. It was a medical facility for homeless people.
Oh.
And so they were well enough to be out of the hospital, but not well enough to be back into the shelters or into the street. And so this was kind of like a transition point for them. And that's where I came into contact with a lot of badass nurses. And I was like, they were doing public health. They were, in this, they were in this facility treating patients, but then they were out in the van going around, giving treatment on the streets. And that's where it clicked for me. I was like, oh, this is what I'm meant to do. Like since I was little with my, stuffed shirt and pants, patient all the way up into here, I'm meant to be a nurse. And so, so that's, through that experience, then I started looking at nursing schools to go to.
Sure.
And, I had friends moving to Chicago. So I'm from upstate New York.
Oh, I didn't know that. Okay.
Yeah.
Okay.
So upstate New York.
Gotcha.
So I'm East Coast,
Okay.
And I had friends coming out to Chicago. And I was like, well, I'll start looking for nursing schools in Chicago. And Rush had this 1-year accelerated program. So if you had a bachelor's in something else and had all the prereqs, then you could do this 1-year nursing program and get your bachelor's.
Okay. And
Yep.
was there any part? It's only 1 year, but any part of you like another bachelor's or like?
No, I know.
Does that?
Well, it's so funny because I actually have 2 bachelors. So I have a bachelor's in biology, and then I have a bachelor's in religious studies.
Oh.
And so I'm like, maybe a third bachelor's is going to get me a master's, maybe? Like, I don't know.
Because there are some master's programs where you come in with a non-nursing bachelor's.
Yeah.
Right? It's
so
okay.
So at the time, so this is back in 2004. At the time, that
okay.
wasn't a thing.
Yeah.
It is now. So
Okay.
now Rush actually just offers direct entry into a master's program. They don't even offer a bachelor's anymore in nursing. So it's if you have a bachelor's in non-nursing, you go into their program and get a master's in nursing.
And I guess while we're on this master's topic, it's like,
Yeah.
who is the ideal candidate for an MSN, for a master's in nursing?
Yeah,
Because you can just go to
Yeah.
nurse practitioner or CRNA, like.
Yeah, so nursing is really, there's a lot of points of entry into
Yeah.
the nursing profession. And so now back in the day when my mom became a nurse, it was the majority were diploma degrees. And so
Right.
it wasn't necessarily college educated. They took classes, but a lot of their nursing training and education was, they were on the floors.
Like on the job, yeah.
In the wards.
Yeah.
And then they moved into associate's degrees. And so in the 70s and 80s, associate degree and bachelor degrees were really popular.
Okay.
And it hasn't been until recently that master degrees have now been the point of entry into nursing.
It just doesn't seem like the next rung after a BSN.
Yeah.
Right?
Yeah.
Okay.
And so now actually the fastest growing nursing profession now are nurse practitioners. And
Okay.
so they, these are nurses that either have a bachelor's or a master's.
Okay.
And they go into a doctorate program.
Mhm.
There are also masters in nursing for nurse practitioners, and so it's weird. Like you can get a master's in nursing, but some are geared towards being nurse practitioners or CRNAs.
Okay.
Others are geared towards just general entry
Okay.
masters. And so different training and education, but still the same degree. And so that's why nurse practitioners are now moving more into the doctorate realm. And so I think by like 2030, the plan is to have all nurse practitioner programs at the doctorate level instead of the master level.
Yeah, some standard, right?
Yeah. Well, and it's kind of, I think, have parity among our other colleagues. So, pharmacists, they get their PharmD now.
Yeah.
Physical therapists get their PTD.
Right.
So
right.
doctor.
Well, there's the big discussion between like physician assistant and PE, right? It's just like a lot of pre-health students are just kind of like trying to navigate like what is the best option for them.
Yeah. And it's people who,
as far as maybe like what you're allowed to do, the work-life balance, things like that.
Yeah, and that's where and I think a lot of people,
even the training.
Yeah, I think a lot of people go into being a PA or a nurse practitioner instead of being like a physician is to avoid the debt. And then what you're talking about is that work-life balance. And so having more ability to kind of, have that work-life balance than physicians would typically get. Although my physician colleagues, I mean, this generation, they're, the old school generation was all about work. And, physicians, in this day and age are like, no.
Boundaries.
We need boundaries. We need boundaries. And so, this is what's great is you've got colleagues, PAs and NPs that can come in and help with that workload. There's enough work for everybody.
Yeah.
Trust me. And that's where, that's where I think the team works great.
Okay.
Between PAs, NPs, and physicians.
Gotcha. So, you went into your master's, or not master's, the 1 year accelerated BSN program.
Yeah. And my plan was to go into public health nursing and be a badass. Like I saw those nurses, in Washington, D.C. But then I fell in love with hospital medicine. And so my first rotation was on a general medicine unit. And I was like, oh, this is cool. This is, you're meeting people at a very unique point in their life. It can be a very scary place. And to be the one to give support and comfort and help people navigate through that point in their life is really special and really privileged. And there's a lot of opportunity to really have
an impact. Yeah, absolutely. I think the amount of time you do spend as a nurse with patients is what medical students are looking for, like romantically looking for.
Right.
You get bogged down with metrics you gotta reach, and it's just you don't get that.
No,
as a physician.
No. And in fact, when, eventually I went on to more schooling and got my nurse practitioner, my first year, I missed bedside so much that I actually took a position as like a per diem, so as needed basis, to work at the bedside because I just missed that one-on-one interaction.
You climb the ladder so high,
I know.
You get so removed from what you first initially fell in love with.
That passion. And so, so I was in, hospital medicine from 2005 all the way up into 2012. And so I worked on the general medicine unit, and then I was an ICU nurse for 7 years. And then in 2013, I started my role as a nurse practitioner in hospital medicine.
And throughout this journey, were there any forks in the road where like I kind of like ICU more? Like did you consider anything at the like flight medicine or anything like that?
And that's what's great about nursing. Like you can go into anything. You could go into teaching. You could go into public health. You could go into look at Lauren Underwood. She's a nurse. Okay. She's a congressperson.
Oh, okay.
And so and she brings that unique perspective of not only being a nurse, but she also has a chronic illness, and so. And then she's taking that into the halls of Congress, which is so cool.
Wow. And
so nursing permeates society. We're found in all corners. And so that's what's really cool. So I had thought about flight nursing. So I'm like, that's pretty cool, And I thought about, like, do I go into the shelters again, start working, and especially in Chicago, there's a lot of opportunity to do community health stuff. And so I found my way into ICU nursing, and that's really
what kind of ICU?
So I was medical ICU.
Oh, medical ICU. Okay.
But my last year I did rotation. So I went through surgical, neurosurgery, cardiac.
Wow.
So I kind of got a taste of of everything.
Yeah.
But medicine has been my favorite.
Interesting.
Yeah.
Interesting.
Yeah.
Well, and why? Because does it touch a little bit about everything?
Well,
or-
like, with medicine, so, with surgical nursing, it's pretty much like A plus B equals C. So you got an inflamed gallbladder, it's infected, we're going to take it out, you get better, we send you home.
Okay.
With medicine, it's a lot more with chronic illness. And chronic illness gets influenced by social determinants of health, family support, finances, a lot of things. And so it's like...
It's a puzzle and it's a welcome challenge.
Yes.
Okay.
Yeah. And so it's kind of like, okay, you've got this chronic illness. How am I going to help you cope with and live with this in a healthy way? And, prescribed treatments, what would be like evidence-based and what's number one recommended may not be functional for that person. So again, what's going to be functional for that person? So, for example, people with heart failure, they have to be on a what we call a water pill, so a diuretic, to help take off the fluid that the heart has trouble distributing. Well, that causes people to pee a lot and urinate. And so a lot of times that's a medication that people will avoid and not take. And that causes an exacerbation. And so then they're back in the hospital. And so it's really saying okay, twice a day would be the recommended dose, but you can only do it once a day. So let's just do it once a day. And then what times would work best? Like in the morning, you're going to be out and about, so maybe take it in the evening because you'll be home. And so it's fun to really
You're kind
work.
of wearing the social worker hat too.
Oh yeah,
huh?
100%. Yeah. And in hospital medicine, it's very multidisciplinary. And so you're pulling in caseworkers, nurse managers, social workers, trying to pull in all these resources, to help people.
Is there any part of you that is frustrated when you don't have control? Like you give them the keys to maybe change a lifestyle or a behavior, and it's really up to them, right?
Yeah, I think when I was younger in my nursing career, it'd be super frustrating because it makes sense to me. Like, why wouldn't you do this? But people are complex, and I don't understand 100% of their complexity or the path that they've had to walk along.
Sure.
And so I've gotten to a point now of saying hey, there's a lot of tools in this toolbox, and you've got to see what works best for you. And it's not up to me to decide that for you, but at least to give you the knowledge and the power to do it. And then it's up to you. It's their life in the end, and it may not be the path I would choose, but that's not my path. It's theirs. And so, for me to be able to support them as much as I can along that journey, along that road, it's all about risk reduction,
And I mean, is there any part of you that wishes you could have follow-ups with them, right?
Yeah,
because you don't really have follow-ups.
not at all. No, yeah, there's a lot of times, because pretty much the patients that I get,
because we used to try. I think there was an initiative a while ago. I think they did it in Wisconsin or Minnesota for paramedicine, community paramedicine, right? Or just maybe creating a segment of the hospital to check up on frequent flyers or people that are recently discharged, and just making sure that they are doing everything they need to be doing.
Right. Yeah. So we, at least the institution that I work at, we do have. So these are, like you said, high risk readmissions, and so our frequent flyers, as we call them, and we have a social work team that actually calls them usually within the first couple days of discharge to call in, check in, everything going well, what questions do you have, were there any confusion?
Sure.
And so we do have a certain patient population that we do flag.
Cool.
Back in the day, it was the primary care physician that would come into the hospitals and manage patients.
Wow.
And so there was that continuity. So they knew this patient, and they knew, but this day and age,
you're not seeing that.
No. I mean, this is my job.
How many
now.
people have a primary care?
Well, I would like more people to have primary care. Yeah, and unfortunately, a lot has to do with location.
Okay.
And so some people just don't have access to a primary care center in their community. Insurance. People don't have insurance that would cover them to get primary care. Even, people, even if they do have insurance, sometimes the copays to see your primary care can be high that they can't afford. And so there's a lot of obstacles for people to actually get plugged into a primary care.
So even with like Medicare, Medicaid, or county care? Okay.
Yeah, so that's yes. So
which is our local subsidized
Yeah.
version of insurance. Okay.
Yeah. Certainly with the Affordable Care Act, that, or Obamacare, which is commonly known as, that really gave people access to healthcare and the ability to get insurance affordably into seeing a medical provider. And so that has certainly helped out a lot. The problem that you get into with some of these either private insurances or public insurances is they can be limited as far as if you are a person that has chronic illness and needs specialty care.
You'll get denied?
Sometimes it won't cover it.
Oh,
yeah.
wow.
And so some insurance companies, so for example, if you come into the hospital and, you need to go to like an acute rehab center or a subacute rehab center because you're just physically deconditioned from your illness and you're just not safe enough to return home. We've had insurance companies deny that. And we send them, again, the best option for them would be going to an acute rehab or a subacute rehab center, but we have to send them home.
Oh.
And they may, and actually the biggest issue we have this with are our immigrant population or undocumented patients that just, we can get them into some county care or some bare bones insurance, but they just don't get a lot of services that they need from it.
Wow.
Yeah.
Wow. And so what is your current day-to-day as a nurse practitioner? Are you more on the admin side? Because you're a professor as well, you're assistant professor as well?
Yeah. So I work in the College of Nursing.
Okay.
Where I teach a few classes.
What's it like to come full circle?
That's really cool. Well, yeah, and this is I started out there 20 years ago as a student, and it's really weird. Yeah. And there are some professors that are still there that it's hard for me to say their first name, right? So I knew them as like Dr. Hicks, and it's like, no, call me Frank. I'm like, okay. Frank Hicks, it's just like, it's just kind of, but it's cool because it's like a family.
Sure.
I've known you for this long, and so and we know each other's strengths and weaknesses, and we can it is like a little family, a little community, so it's fun. So I teach in the acute care nurse practitioner program. And then, but all my clinical work is hospital medicine.
Okay.
And so, I manage a group of patients on one unit. So I'm dedicated to one general medicine unit. We've got 32 beds. I see up to 9 patients on that. And it can range from I feel like I'm a jack of all trades, a master of none. Ooh. And so because I have to know a lot about everything.
Yeah.
And so, I'll see heart failure patients.
Kind of like ER?
Yeah, kind of like
right?
ER.
Okay.
Yeah, 100%. Yeah. I don't, ER sees a lot though. So at least I get specific towards like, yes, this is a medicine patient.
Okay.
Yeah.
Okay.
So where ER, you get psych, you get
trauma,
you get everything.
Okay.
And so, my hat's off to ER people. They got a tough job.
Mm-hmm.
But even I say that, but like with general medicine, we'll have patients that their main issue is psych related, but they may have some medical issue that they can't be in the psych unit. And so they're over. So we saw this a lot with COVID. And so, a patient comes in primarily for psychiatric issues, needs an inpatient psychiatric stay, but they came up positive for COVID.
Sure.
They may be asymptomatic, but they don't want to put them in like a lockdown unit.
Sure.
And so they put them on general medicine to to get the treatment that they need. And so I guess I deal with a wide range.
And right now, is that a good balance for you, doing the teaching as well as the clinical aspect?
And like I was saying, like nursing, you can do anything.
Yeah.
And so I'm really starting to branch out.
And was it becoming the nurse practitioner that unlocked this door to do kind of both of this?
For sure.
Okay.
For sure. Yeah. So like, to teach in the college, I mean, we have people that have, bachelor's and master's, that are in the college teaching as like clinical instructors.
Yeah.
But you need that terminal degree of the doctorate to be able to be like a professor.
Okay.
And that's something I wanted to do, is to have more role in curriculum development.
Okay.
And so that's fun. It
Yeah.
challenges a different part of my brain.
Sure. Like how would you have liked to been taught if you were to do it all over again, right?
Yep.
Okay.
And what's changed, and
Yeah.
so what needs to change in our curriculum. The people that we're seeing and treating, it's based on society and politics. Things are always changing, and so what do we need to teach nurses in order to equip them to be able to adequately respond to the needs of the community right now?
Yeah.
And so that changes. And so, for example, what I didn't get a lot of, but now that we're really pushing is, how do I affect policy? Because policy drives change. And if we want to change what's going on in our profession or what's happening in the lives of our patients, we need to know how to talk to politicians. We need to know how to write op-eds. We need to know how to, speak a nurse's voice to the public,
Right,
and get
right.
people to understand. And so, so it's fun.
Right. Is there currently a shortage in our area or nationwide of nurses? How are you seeing what are you seeing with like application numbers?
Yeah. So, I mean, we're always talking about a shortage of nursing.
Yeah.
And that's always, it's been since my mother was a nurse,
Oh.
back in the 60s,
Okay,
they're always talking about it. What we're seeing now as far as numbers, yes, we're going to be entering a nursing shortage. And a lot of that, I think it's in all sectors of life, though.
Of life or healthcare? Or?
Life.
Oh, life.
Because we've got the baby boomers that are retiring. And so, there's a big gap that we're going to start seeing in jobs that were formerly taken up by, the baby boomer population as they retire. And so nursing is not immune to that. And so, we've got swaths of nurses that, with their experience and their knowledge, just gone, retiring. And we've got this, newer cohort of younger nurses that are, taking up the helm.
Yeah. I hear stories of like new nurses training newer nurses.
100%. Yeah. And what's interesting that we've seen nationwide is certainly the pandemic has really burned out nurses.
What would be, and we can't speak for every hospital system, but like the average number of patients per nurse?
Oh, yeah. So on average, what you typically want to have is like, if you're like in an ICU setting, one nurse for 1 to 2 patients.
Okay.
On the general medicine unit, it's usually 4 nurses to 1 patient, or 1 nurse for 4 patients.
Okay.
Right.
Okay.
And then things kind of change as you go to like acute rehab. Or skilled nursing facilities.
It gets higher? Okay,
yeah.
okay.
Yeah, because they're not as acutely sick. So the less
Gotcha.
acutely sick they become, the more patients a nurse can have.
And how do some hospital systems like stretch that boundary?
Yeah, so it's interesting. So you'll have some places like California that actually legislate this. And so they'll say like, it's a state law that it's mandatory that you can only have 1 nurse for 4 patients if you're on a general medicine unit. Places like Illinois, which don't have those laws, rely on various things like acuity. And so there are different tools that hospitals will use to kind of judge how sick a person is.
Okay.
And based on those numbers, that will tell you how many nurses that you need. And so some nurses can have 6 patients,
Wow.
but they're at a lower acuity, so they're able to manage that. I get nervous when you legislate patient-nurse ratios,
Yeah.
only because what'll start happening is to maintain a high nursing workforce like that, hospital systems had to start letting other things go. So ancillary staff or supportive staff. And so, okay, we're going to have all these nurses to keep these ratios. We're not going to have a unit clerk.
It's not in their budget
Right.
anymore.
So we're going to have to get rid of the unit clerk.
Oh.
We're going to have to maybe get rid of an evening housekeeper to be able to afford to have these nurses to meet these mandated ratios.
Yeah.
So then who picks up that? It's going to be the nurse. And so they get their ratios, but then they may have to take on other responsibilities to offset the cost.
So, before we started recording, we were talking about agency life and like, where does the funding for agency nurses come from?
Yeah, so that's
'Cause it seems like when nursing unions go on strike,
right,
and they bring in these agency nurses
Yep.
for double or 3 times the rate. It's
Yep.
like you can afford this, but you can't.
right.
So
right.
yeah, how does that work?
So agency nursing. So there's a lot of like companies out there that have agency nurse or agency nursing companies, and they'll send nurses out all over the place.
Okay.
And usually it's to hospital systems or hospitals that are short nurses. And
Yeah.
so for hospitals, it's a short-term fix to respond to an immediate crisis.
Okay.
So whether that's, a strike that's happening or if there's like a natural disaster or something
Sure.
like that happens, or COVID.
Yeah.
And so they'll bring in agency nurses. And so it's long-term financially doesn't make sense.
Okay.
And not
on
doable.
average, these are like 18-week contracts.
So yes. So they can be, they usually can be anywhere from like 6 weeks to, to 3 months.
Yeah.
Where these hospital systems will contract with.
Okay.
Ideally, hospitals don't want to be agency free,
Right.
Because it's just too expensive. But again, it's that short term fix to whatever's going on.
So do you think? I mean, and what is the current pulse on agency nurses that are in agency?
Yeah, so we're
Is
using
it
them a
drying
lot.
up? Is it drying up, or there's?
It's going to start drying.
It's going to start drying up.
Yeah. As COVID has like now become like kind of like, people aren't dying anymore from COVID for the most part.
Yeah.
And not like they were. And so the agency was being used for hospitals that had become overrun. All hospitals were overrun with patients. And so these were healthy people that normally wouldn't seek hospital care that they were now seeking hospital care because of COVID. And so the nursing infrastructure that they had at the time could not support the influx of patients that they were getting. And so that's where they were really needed. I would say now out of the pandemic, hospitals are still using agency because nurses are leaving the bedside because they got so burnt out with COVID and in the hospital setting that they're like, I've got to go into primary care, school, just another industry completely. And so we've had to use agency nurses to help respond to the influx of nurses that left after the pandemic. I think that's now, we're starting to now replenish the nurses that we lost. And this is nationwide. So then the nurses that we lost, and to get more of a core staff.
Sure.
Yeah.
Can you speak on like how to cultivate an ideal like workforce or not work life balance, but like a culture at work amongst the nurses?
Yeah. So it's when you work in a hospital, and especially for nursing, it's very different from the rest of your friends. You come into very unique situations, and you deal with life and death every day. my sister will tell me all the time, like, how can you be so flippant about talking about death? And I'm like, I have to cope. Like, that's what we do,
Yeah.
And it's not meant to be disrespectful in any way, or minimize the seriousness of a situation,
Sure.
but it's a way to cope. And so, so you will see this camaraderie among nurses very early on, because they're sharing a very unique experience. Not only the experiences that they deal with patients day to day, but then also the shifts. So a lot of places do like rotating nights. So
Sure.
you'll do nights and day, and so you work weekends, you work holidays. It's a very unique role,
Yeah.
profession to have. And so I think we talk a lot about creating a healthy work environment, and a lot of that starts out with respecting your coworkers, and like everywhere, and having this kind of code of conduct. And so we talk a lot about and it's an old saying, oh, nurses eat their young, which can be true for some places. But what I have found at where I work is that we're all there to support each other.
Yeah.
Because at the end of the day, what matters is the patient.
Sure.
And so, for example, if you come to me with a question and I intimidate you or bully you, you're not going to come to me next time with that question.
Yeah.
And who's going to suffer in the end? It's going to be the patient.
Yeah.
And so that's why it's really important that we work hard on keeping open lines of communication, respecting each other and the roles that we do. And so we learned a lot with COVID, that, one of the best units I worked on was an ortho unit that got turned into a COVID unit. And these nurses, they dealt with hip replacements and joint replacements, and these were surgical.
Yeah.
And all of a sudden they're dealing with a pandemic, a medical pandemic, and they killed it. Well, that's not a great way to say it. They knocked it out of the park. Oh God. So, and what was great was, not only did nurses come together, but environmental services came together. So, the environmental service, so this is housekeeping staff.
They don't get enough credit.
They were the unsung heroes, because they were going into these rooms and cleaning these rooms and coming up with protocols of because we didn't know what this virus was doing. We didn't know how long it was living on surfaces, and they were going in there, exposing themselves every day, and then making sure that the environment was clean enough to keep me safe, to keep patients safe, to keep everybody safe. And so the respect that we found among all people that were on the unit was just incredible, because we all had a role to play.
Yeah.
So
Are there some protocols to minimize burnout as well?
Yeah. So we've talked a lot about that within the nursing profession, is how to, because you're dealing with heavy stuff. And emotionally taxing stuff, not to mention it's physical labor, and so there's a lot of things that we have in place. So one of them is mentoring. And so having a mentor is really important, so that you can have a person to go to say hey, this is what I'm dealing with. How did you deal with this? Or this is what I'm feeling. How do I manage this? We have what we call a nurse residency program. And so these are brand new nurses in their first year. And so part of, I think it's 4 hours a week that they spend meeting with other new nurses, being mentored by a senior nurse. And they talk about a lot of different things. And some of the sessions that they'll go to is how do you de-escalate an angry patient or an angry family member? Because, one of the things that you'll encounter as a nurse or a nurse practitioner or healthcare provider in general is, family members will come in, or even patients, and they're confused. And they're frustrated.
Probably got lost on the way there, right?
Yeah, right. And, they'll feel dumb and don't know what's going on. But instead of owning those feelings, they'll project them onto you.
Sure.
So,
But don't take it personally, right?
right, exactly.
Okay.
That's what's hard
Yeah,
is,
yeah.
but it took me many years to start
Yeah.
realizing like, oh, you're calling me dumb. You're calling me stupid. I don't know what's happening. It's because those are your feelings. You're confused. You're scared. And so recognizing what's happening, just poor coping,
Sure.
and then being able then to address that. And that takes a lot of years of practice.
Yeah.
Emotional checking yourself. Like, okay, this isn't a personal
All I'm
attack
trying to
on
do
me.
is save your family member.
I know, right? Do you realize what I've been doing? And so it's learning skills like that.
Okay.
To be
That's
able
cool.
to.
And that's a sign. You don't just like find a mentor. Like,
Right.
Yeah.
Right. Oh yeah. Well, sometimes, and it depends on. There's a lot of different type of mentoring programs out there, so it depends on what you're looking for. So
Yeah.
whether it's a professional mentor to see like where do I take my profession next, versus hey, I'm brand new, I need support in navigating this like new profession. And then we also have like, we promote like a lot of like self-reflection. And so for a while this was before COVID, we had like cold lavender. And so if we noticed, so we talked about like, we have cold blues when a patient is in trouble. We'll have a team that responds and deals with that. If there's a coworker that has had like a very emotional day, or we can call a cold lavender. And so we'll have somebody from either like volunteer services come up and bring like snacks, drinks, just something to and recognize like, hey, you need 20 minutes. I'm taking your pager. I'm taking your patient assignment. Relax, chill. And so that's when recognizing a co-worker in distress and that they need something. What was great is we had wellness rounds during COVID, and it was this psychiatric and psychology department that came around and just said, hey, do you guys need to do debrief? They bring snacks and stuff like that, which was great.
Wow.
But then it was also like, hey, I'm here to offer my services. Like, was there a particularly hard day that you had today? Let's talk about it. And so that type of self-care is like super, super important.
And it's I guess it's like learning to be receptive and open to that as well. It can be hard to just open up like on the spot, right?
Oh
Like,
yeah. Oh yeah. Yeah. But it's again, like COVID just brought up really unique opportunities. And so people that normally be like, no, I'm fine. People were like, yeah, I got to talk about this, and,
Cool.
or like, we were like, we got to make a TikTok. Yeah. I was making TikToks, like TikTok, but it was like, I need to get out of here. Let's go up onto the rooftop. Let's like make a silly TikTok with a dance. And it was so therapeutic.
Yeah.
And
oh yeah, they do yoga on the rooftop.
Yeah.
Yeah.
Yeah. We had stuff like that, And so, and it was cool, so my partner, he's a professional dancer, now retired. But he had seen on TikTok, and he's like, yeah, a lot of healthcare professionals are doing like these TikToks now. And he goes, that's the power of dance. It's just, it helps people cope and deal with whatever stressors
it's
that
release,
they're, it's release. And a lot of healthcare providers went to dance on TikTok to do that. And so, we were discovering different creative outlets that we didn't know that we had, but we were almost forced to discover because we needed to cope with just kind of the scary situation. So, yeah.
And on the flip side, you had some very cringy healthcare providers create cringy like TikToks of like planning to cry because they lost a patient or something. It's like, ooh.
No, I know. Yeah. And that was, some people wanted to capitalize.
Yeah,
on,
right. And when it's like,
this is not genuine. Not genuine at all. Yeah. It's funny. We had this, some people were like, when they got admitted for COVID, they were like calling the radio stations like, yeah, I'm a patient with COVID. Like, and they were getting interviewed. I'm like, okay, come on, But then again, we didn't know what was going on. So I think as any voices that we heard, I think people were eager to hear.
Sure.
Because again, it was such a mystery and so scary. So,
remember the nurse that paralyzed her patient, I think at Vanderbilt.
Yes. Yeah.
So this
Yeah.
quick story was like I think the patient was about to be discharged, but they needed a head CT scan from a stroke to verify there's no more bleeding.
Mhm.
But they're anxious of small spaces,
Mhm.
claustrophobic. So they were about to give Versed, but the Pyxis, like they took out a different medication, a paralytic, Vecuronium. And I mean, if you've ever given Versed and or Vecuronium, you know that you got to reconstitute Vecuronium. So in my head, it's like in my perspective, it's an easy mistake to not make, I guess, or it's yeah, right. So
Yeah.
what were some takeaways, if there were any discussions after that incident to prevent something like that from ever happening? Because in our class, in our EMT class, we teach the 6 rights, right? And even if you did that by yourself or with someone else,
Right.
like, come on. I mean, and I know like there's maybe short-staffed and there's a
Sure.
lot of pressure on you to perform.
Yeah.
So
Yeah.
what were some other takeaways?
Yeah, I think I think an important concept that I really go by is something called why am I forgetting on the name now? It has to do with justice. I can't remember the term exactly right now, but it's basically taking an error like that,
Yeah.
so an error that happens, a just culture is what it
Oh.
is. So a just culture.
Yeah.
And so it's taking an error that has happened and analyzing it and saying, what were the system failures in place? And it could be anywhere from there's a breakdown in one of the systems that led to this error, or was it just a blatant override of known policy?
Sure.
And so I don't know enough about that case.
I
But-
heard there were some overrides to the Pyxis.
Correct. Yeah. And so, again, there are a number of things that we have in place to prevent errors from like that happening. One, it starts with the order entry, and so a provider puts in an order. It has to get verified by the pharmacist. Pharmacist verifies it, and then it gets put into the Pyxis. So the Pyxis is this medication machine that a nurse has to go into, pick a patient, and then pick the medication that's on that profile. There are, in cases of emergency, that we don't want to delay any life-saving medication, that a nurse can go into the Pyxis and override and pick
Wow.
a medication. Sometimes it's restricted as far as what those medications can be. And so a nurse can override that if the Pyxis machine isn't stocked correctly. And so there's drawers that pop out, so say I pick Versed, drawer pops out and I grab the bottle. I'm assuming that it's Versed,
Sure.
but it could have been stocked incorrectly.
Okay.
And so that could have been a breakdown. When you go into the patient's room, you have to scan the medication. So there's a little barcodes on all medications that we give, and it populates into their medical record. And so if I scan a wrong medication that's not in their medical record, I can't give it, or I can't chart that I gave it. Again, it doesn't prevent me from giving the
Yeah,
medication.
because usually you chart afterwards anyway.
You can, yeah. Right.
Or
And
like
so-
a red flag will come up and be like, okay.
Yeah, and so you have to scan the patient's wristband,
Yeah.
and then you scan the medication, and again, that's another like double check.
Yeah.
And so, if the nurse had overrode, why she would have picked, not Versed, or maybe she thought she was picking Versed. There's a lot of like safety steps that probably were skipped. Yes, and especially sometimes there's like a 2-person sign off, and so you have another nurse verify, like,
Yeah.
I'm giving this. Is this what you're seeing? This is what we're seeing.
Right.
So yeah, there are probably a number of, like you said, the 6 rights before giving medication. Right patient, right med,
Yeah.
right route,
Right
right
dose,
time,
yeah.
right dose.
Yeah.
So yeah, the number of things that went into it. You with a just culture too, what you would look more at is not only what were the safety overrides that were ignored, but what was that nurse's assignment like? Was it too much? How many hours did she work? Was she working 12 hours for a week? Was she working 12 hours for 5 days? Fatigue can play a lot into that. Was she on a double? And so it's looking at bigger systems issues. I know a lot of nurses talked about that on my unit because she got prosecuted and charged and convicted. And so nurses were like, could I get convicted for a mistake like that? I'm like, well, if you follow the right protocols, you shouldn't. That should prevent it. And this is a very, very rare case.
And what was the divide? Because to some, it's very clear. How could you make a mistake like this? But then I did hear a lot of perspectives of like worried and like could something like that happen?
Right. Yeah, and I think part of it is because systems do fail. These are systems built by humans and humans err, and so people do worry like, what if somewhere in that chain there is a breakdown, but then it ends up on me at the end, and so the last thing nurses want to do are hurt patients or, and that's the, we're always going in it with good intent.
And then there's always that sentiment of like, you're going to be the first to be the scapegoat.
Right.
Sometimes. And
100%. Yeah.
What am I doing this for if I'm just going to be like,
I know.
Cut, like.
I know. Yeah. Well, and nurses are the last line of defense. And it's tough. That's why you got to be badass to be a nurse. I've learned.
Yeah. So any good advice for new nurses?
I think one, you don't always have to go into hospital medicine. So nurses think like, I have to cut my teeth in the hospital. And you don't. If public health is where your heart is, go there. If academics is where your heart is, go there. It's always
it's not a requirement to have like experience prior to these things.
Okay. Nope. It's always I always say wherever you feel called to or whatever inspired you to become a nurse, that's where you want to go. The second thing is get a mentor, and that can be an old professor. That could even be a
preceptor,
that you had.
Okay.
Just someone that you can stay in contact with. It doesn't necessarily have to be from your institution. Just someone that you can say like, hey, I got to run this by you. I had a hard day. So always having that go-to to get a different perspective.
Sure.
Because that's going to prevent you burning out. Third, always learn. You're always going to be learning. You're not going to know everything. Things that were in one day are out the next and then back in.
Yeah.
And so, medicine is always changing.
Right.
And so you want to always be learning and always keeping that up. Joining a professional organization, incredibly important.
Like which one?
So usually whatever profession or whatever specialty you're in. So if you're an oncology nurse, joining the Association of Oncology Nursing. If you're in critical care, the American Association of Critical Care Nurses.
Okay.
Then I always make a plug. The American Nurses Association. They're the national organization. They've got a policy and a political arm to join, and it's like by state as well. And so getting involved with the ANA because they're the ones that you can really make a change.
Sure.
As far as policies, whether again it's about patient care or about the nursing profession, and so that's really important.
Gotcha. To bring it back to the opioid overdose.
Yeah.
How long has the initiative to put these vending machines up? Like how long has that project been going, and what's the current like air on it?
Sure. Yeah. So the opioid epidemic, really started off in the 90s. And this is when, I'm sure you've heard of this, where pain is the fifth vital sign, and the Joint Commission, or the Press-Ganey score. So I don't know. Press-Ganey is a survey that goes out to patients, and based on those scores, it can affect reimbursement for hospitals. It can affect quality standings that hospitals have. And one of the questions that they ask is, was your pain adequately controlled? And so this concept of pain control and pain is the fifth vital sign really spurred, I feel, the opioid epidemic, because it really forced or incentivized providers to start prescribing and treating pain, which is important. But unfortunately, what happened as these opioids were becoming more and more popular, you had companies that produce opioids, so like fentanyl, morphine, Opana, hydrocodone. These are synthetic versions of opioids. They started doing these campaigns saying that they're completely safe, non-addictive. And so providers were like, well, it's non-addictive. It's treating pain. I'm getting good scores. Like, there's no problem. Well, it became a problem quickly. And so, throughout the early 2000s, this has really ramped up. And, particularly in Chicago, the opioid, like all communities, is a problem. And so there's been a number of years that different organizations have been focusing on this epidemic. Governor Pritzker had released an executive order looking at really doing targeted efforts to prevent addiction in the beginning, then treatment options, and then addressing overdoses. And so this has been something that's been the governor has been really focused on, and particularly in communities that minority communities. And so what we've seen is the opioid epidemic has disproportionately affected the Black and brown communities. And there's lots of reasons for that. One of the reasons is, actually JAMA, just the Journal of American Medical Association, just released an article study showing that Black and brown people are less likely to be offered treatment for opioid addiction than white people. And so really it's the medical community that has failed to respond to this epidemic among minority communities. It has to do with access to treatment and actually having it addressed. We have seen, and we don't have the numbers right now as far as how many overdoses happen on the CTA particularly, as compared to just like out in the general community, but it has been an issue. The highest rates of opioid overdoses are actually on the west side. And so that's West Garfield, Austin, Humboldt Park, are the top three communities.
I would hear that the medics would just keep Narcan in their pocket, in the visor, just ready to go.
Yep. And there are different, like the night ministry, Loyola has a team, and they'll go out and they'll park by CTA stations, and then the CTA attendant will come out and say, like, hey, we think somebody's overdosed, so they'll go and see if they need to administer Narcan. And that's great, but I don't think it's all that effective.
Effective how? What do you mean?
Because where Narcan needs to be is where the people are. And they're on the train, they're on the bus. And so my hope and my wish is for every CTA bus, every CTA station, and every CTA train to actually carry Narcan on them, to be able to get that life-saving medication to the person that needs it in real time.
Remember those like condom vending machines in the bathrooms?
Yeah,
similar to that.
Similar to that, 100%. Yeah, for sure. Having that access, I think, is really important. It's great right now. They're working on getting a vending machine at the 95th station on the Red Line, which is great. But it's one station. It's not where we have the highest overdoses, which is on the west side.
So who decided to put it there?
Well, so it's a task force, and they've been working with the Chicago Department of Health,
Okay.
CDPH, Chicago Department of Public Health, has been driving this initiative and working with the CTA.
Okay.
And so this is how it's getting installed.
Are CTA workers unionized?
I believe that they are. I'm not 100%
And like it's probably
sure.
not in their contract to.
Well, that's
right?
So this is the rub, and I understand and I get that the workers, one, they don't want more responsibility. They have so much responsibility to begin with. To administer a life-saving medication is not something that can be very intimidating.
Sure.
And the fear of, one, if I administer it to somebody who's not overdosing,
Sure.
what are the consequences to me? If I don't administer it to somebody and I have it in my possession, what are the consequences? So I think there's a lot of fear of the responsibility. At the end of the day, there really isn't or shouldn't be any fear.
It's not your responsibility.
It's right. And so you have something in your hands that you can use or not use without any repercussion, basically. And so if you have it and you want to use it yourself, great. If you have it and you want somebody else to use it, great. You can say, I have Narcan. If somebody wants to give it, here it is.
Gotcha.
Or if you just don't feel comfortable, you don't have to use it. But at least it's there and in the hands of anybody to use. And it won't cost the CTA anything either.
Okay.
Because we've got government, well, now this is what's going to be interesting. So now that it's over the counter, the amount of government funding that goes to like providing free Narcan to different
Because it was in
facilities.
public libraries too.
It's in public libraries,
Yeah.
yeah.
For free.
For free.
Yeah.
For free, yeah. And so like, at Rush, we have a community health branch, and we get free Narcan all the time that we distribute to people. I'm always asked, I'm like, my girl Eugenia, she's like one of the head people as far as distributing. I'm like, you're my dealer. Like, I've got friends, they're going to a rave this weekend. Can we have some Narcan?
Yeah.
And she's like, yeah, how many boxes do you need?
Yeah.
I'll give it to you. And so I'm just, handing it out like to, people. There's actually, Cigna has an initiative of having Narcan newsstands. And so there are like newsstands with Narcan in there. And so I'm trying to get, Rush to have like a Narcan newsstand on our campus. There's some logistics as far as like, we can't be promoting any like particular product or, things like that. But I'm like, but we have this life-saving medication that we can have readily available to our patients. Like, why would
That's
we
so
not
wild.
want to
'Cause
do
people
that?
that probably get this aren't thinking of the company that made it. It's so wild.
And we give it out free all the time from our institution. So it's like, we're not promoting life. It's not a product. And so that's what it's really about. So there's maybe some legal and logistic things to get through, but there's a lot of just creative initiatives now being put forward in order to make this accessible to people.
How much would it be from the vending machine? Or is it free?
It's free.
If it's free, what's stopping someone from just getting all of it? I don't know. Like,
well, and to be honest, they could, so it's not like a medication that's going to get you high.
Yeah.
It's going to actually do the opposite. So I don't know if there's a lot of incentive because and rightly so, people are like brainstorming like, oh, what if a kid gets it and takes it? Well, it's not, nothing's going to happen.
Yeah.
So if a 7-year-old grabs it and, gives themselves a nasal spray, they're going to be fine.
Okay.
And so there really isn't any major consequences. And, it gets emptied out. We've got a program that we can restock it for free. Yeah. And so it's a win-win. But I think there's stigma around it. And so
like if you're seen trying to operate this vending machine, like
right, like, oh, why do you need it? And it's but in a lot of times we even recommend Narcan to patients that are on chronic opioids. So maybe they have chronic pain and so they're on something like Vicodin.
Sure.
They should have Narcan in the house. in case they do an accidental overdose. Because sometimes when pain gets really uncontrolled, people aren't thinking how much they're taking, that they just want to get their pain under control.
Sure.
And that can lead to an unintentional overdose. And so having Narcan, like someone with a peanut allergy with EpiPen, should be available. You know, we have, there is an article that I think it was the New York Post ran, talking about, well, we shouldn't give Narcan or have Narcan available because that's an infringement on that other person's body and their right to administer Narcan if they're overdosing. We would never say that about giving CPR or using a defibrillator on a person who's having a heart attack.
Right.
Like, you know, that's essentially what Narcan is. It's, you know, it's CPR for a person that's overdosing. And so, but it's so stigmatized because it's an opioid. And so people say it's their fault, you know, that they're addicted. Why are we helping them? But
yeah, I mean, there are a lot of people that just hold the perspective of like,
Yeah.
I'm going to mind my own business.
Right.
And until it happens to a loved one, it's like you don't really think twice about
Yeah.
someone like unresponsive on the CTA.
Yeah. And in fact, the CTA Narcan task force that I'm a part of, one of the women that's on there, her son passed away on the blue line.
I think he was a first responder too.
Yeah. And he was still breathing by the time EMS, right before the EMS got there, but by the time EMS had gotten there,
Wow.
he had passed away. And her perspective was, if, you know, we had Narcan, you know, could his life be here today, you know? And, you know, people will say, like, you know, does somebody deserve it? Maybe, maybe not, but I would say...
We're not there to judge, you know?
No,
Yeah.
we're there to give a second, a third, a fifth, 100th chance at life. And that's what it's about.
And whatever happens after, like, if they wake up is on them too,
Right.
Because, like, I wonder how often the night ministry, or I know there's, like, groups of healthcare providers that just go out to different camps and they might administer Narcan, but what if this person wakes up, you call EMS, and they refuse care?
Which has happened all the time. Yeah. Again, it goes back to those choices where we're like, that's hard, you know, that's not the choice I would have made or I'd want for you, but at the end of the day, it's their choice. But you know, that's what Narcan is about for me. It's giving them that choice so that, you know, this overdose may be your last and you can keep living. And so that's always my hope, that this is going to be your last overdose. We're going to save your life and you're going to live the life that you want to live. Because I can tell you, you know, people that have addiction to opioids, they're not living their best life and they know it and they're not happy. But they have a disease and they have an addiction. And sometimes they haven't been given the opportunity to get better. Sometimes they haven't had the access to get better. And so it's giving them that second chance.
How much? Yeah. Just stop me if we're beating you know, keep beating the same drum. But how much do you encourage? And I don't think force is the right word, but what you are someone that has the resources and the tools to help someone battle addiction. At what point do you stop, like, extending your hand, or like, is your hand always extended? But like, what if they just never reach out?
Yeah. You know, so I just had an experience just yesterday or 2 days ago with a patient that he's a frequent flyer in for various alcohol, opioid related issues. And, you know, and again, for withdrawal. And we have an awesome addiction medicine team. So we have a team of specialists that actually are certified in addiction medicine, comprised of physicians and social workers that's all they focus on for that patient. So anyways, he's in again and got him through withdrawal, getting ready for him to discharge. And he's like, you know I keep coming in here, but just don't give up on me. And, you know, that just really, and I said, never going to give up on you. And and it's tough, because I can see he's trying so hard, and he's trying different things, and he's tried different programs, and it's hard. It's hard based on his life experiences and what he's going through, and it's really hard. So yeah, he's just always extending that hand.
Yeah. So what's the timeline looking like for the vending machine?
So, well, interesting. Thursday, I have a meeting about it.
Good.
So
Good.
I'll have more information. Again, there's logistics between, getting the CTA ready, and then getting the vendor ready, and then how that's all gonna work out. But we're hoping by later this summer, that it's gonna be installed into the 95th station.
I wonder if like these can be like a mobile, like if someone can set up like a trike. I have a friend that like used to sell his cold brew on a trike.
Oh, nice, yeah.
And you just set up shop at like the gate of Lollapalooza or like wherever. No, Taylor Swift was in town, or Beyonce, whoever, like large gatherings, and you're just offering it like.
That is like an awesome idea. Like I just have a vision of like a food truck, but it's a Narcan truck, and you're set up to like these food vendors and like Narcan, free Narcan. Yeah, exactly. You go to where, the highest risk, and so, certainly venues like Lollapalooza or Pitchfork or anything like that, that would be that's a great idea. Can I share that? I'm going to share that with like the task force. I think that's so cool. Yeah. It might be already being done. I don't know. But I love that idea.
Along with like destigmatizing like you as a person trying to obtain Narcan, kids, especially college kids, are going to experiment, maybe high schoolers too. And it's just like your intention may not be to do opioids, but whatever you end up taking might be laced with fentanyl or something else, and you might put you in an accidental overdose. So it's just understanding that anything can happen, especially when you're experimenting with drugs.
Right. Yeah, and I mean, we've seen this with like, people who are using like cocaine or methamphetamines, which Narcan does not work on, but it does get laced with fentanyl. Yeah. And so
what are these dealers thinking?
I don't know. Money. Yeah, I know.
Because it's cheap, right? To make fentanyl?
Yep.
Okay.
Yep.
Okay.
Yeah.
Maybe the addiction process. I got to get a drug dealer on the podcast.
Right. You really do. I think that would be. I think that would be really interesting. And even talking to somebody who's like active in addiction right now, it would be really interesting. Again, humanize it, because people have this stereotype of what somebody addicted to opioid is like, and it's really, it can be uncomfortably familiar to hear their stories, to be like, wow, I could see myself as you, and it's because, but it all depends on what resources you have available and coping techniques that you have, and that separates me from somebody being addicted. So
what advice would you give to someone trying to establish something similar, let's say on a college campus?
Oh yeah.
Like, who do they have to talk to? Like, what do they got to establish?
So I think if you're looking at like particularly like college campuses, like starting with like student life and the health center, that is like somebody definitely that you want to chat with. I guess it depends, like whether it's a private or a public institution, that you might come up with some challenges. But like, those type of initiatives, and like bringing any statistics that you have, that, I mean, data is power. And so if you have numbers to show like, hey, like this percentage of, people either on our campus or in our surrounding community has like an addiction, an opioid addiction. There are 3 million people in the United States, 16 million worldwide, that have an opioid addiction. So it's big, it's huge. So bringing numbers like that and saying like, hey, this is the benefit. Like, would we ever say we wouldn't carry, an EpiPen? No. Like, of course, every college campus and health center has EpiPens because it's life-saving. And so same should be for Narcan.
Yeah, I wonder, like, he has the person I'm thinking of, like, he knows someone that overdosed and died from it. And the college isn't really he's showing much effort to implement,
Yeah.
takeaways that they learned from that incident.
Yeah. And that's why, and sometimes starting at the top or starting with administration is usually, and this is what I've learned, being in college and being a professor, change happens at the grassroots. And so if you have enough students making noise about it, the more attention you're going to get. And so this is where you start utilizing journalists, getting journalists to, and that's it. My brother's a journalist.
Okay.
And when I had this experience on the Blue Line, I went to him and I'm like, what can I do? And he's like, get somebody to write about this. That's what's going to make the change. And he was absolutely right.
Yeah.
He was absolutely right. And so, making enough noise and getting enough focus through media, whether it be newspaper or TV, local stations, the local, radio station that, some college campuses have, that's where you start. It's grassroots.
Okay.
Yeah.
Cool.
Yeah.
Is there anything you'd like to share that we haven't talked about already?
No, there's a lot that we
chatted
about. Yeah. Nursing is the best profession to go into, and we got to get Narcan on the CTA. So,
if you want to be found, where can people find you?
Sure, I'm on LinkedIn, Erik McIntosh. I do also have an Instagram, Erik McIntosh, but I don't ever use it.
Okay.
So probably LinkedIn is probably the best way to find me. Yeah.
Awesome.
Yeah.
Erik, it was a pleasure. Thanks for hopping on.
Yeah. Thanks for having me. Appreciate it.
Thank you guys for tuning in, and we'll see you in the next one.